So there was one thing I forgot to mention that we also do that's sort of similar to what we're doing tonight. So this is community conversations, but we also, on the second Wednesday of every month, from 10 to noon at Cafe Dolce on Brooks, have even more casual conversations about end of life, and it's called the Death Cafe. And I know that name scares a lot of people away, which is why you should come, right? Because we're going to die. But it's really more focused on how to live until you die. And our idea is that if we talk about these things, it makes living so much different and so much more enjoyable because we're focusing on quality of life. So we're not going to kill you if you come. That's not the idea. We want you just to come talk.
Don't worry about the drinks.
Right. There's no Grim Reaper there that I know of so far. So that was ironically this week, but it's always on the second Wednesday. So come if you would like. In Cafe Dolce, they have that side room where all the plates are. We reserved that room, so be looking for us there. We're not sitting out in the more common area. So that's where we'll be.
Is it the Cafe Dolce on Brooks or in the mall?
On Brooks. Yep, the one on Brooks. So tonight we're going to talk about how doctors want to die, and we have 3 physicians here that are joining us, and I'm sort of excited because they're all a little bit different in what they've practiced. So this is Dr. Pat Beatty, and he's an oncologist, and he works out at Community, and he's been doing oncology for
35 years.
35 years. So he will be talking about that. And this is Dr. Tim Caramore, and he's with Providence St. Patrick Hospital. He's a hospitalist there. So he works in the hospital and rounds on patients in the hospital, and he's been doing that for
A year and a half.
a year and a half. And this is Dr. Liz Rantz, and I only know about your experience as a physician working in the prison system, although I'm sure you've done much more.
That's enough.
That's enough. For how many years?
Well, between the 3 prisons, about 15.
About 15 years. And so we do have just a lot of different people and their experiences with patient care, and so it'll be interesting to sort of hear what their concepts are and how they think about the way that they will die. But first, we're going to listen to this radio lab and sort of get some information that will maybe spur some conversations for us. So take it away.
Listening to Radio Lab.
If it isn't loud enough, anyone just raise your hand.
From
WNYC.
Louder?
NPR. Hey, I'm Jan. I'm Ron. This is Radio Lab. Oh. Somehow it just sounds so different.
Yeah.
Something just got. That's really how we did it? We could just do it differently.
Let's do it differently. Maybe try go first.
Go first.
Shock you.
Yeah, do it.
Hi, I'm Robert Coley,
Get up and run.
and this is Radio
The
Lab.
podcast.
Not
Why don't we talk
Maybe
Miss Yvonne?
Couldn't possibly have maxed it out. Maybe.
Well, this story starts with a doctor, a guy named Joseph Gallo.
Hello?
Can you hear me, Jim?
Yeah.
Oh, okay, great.
Yeah.
The fan went off.
I feel like a celebrity
Like that.
sending a sound person here.
Joe's an MD, but he's also a professor.
Johns Hopkins University.
He's been working on a study that I think find overly fascinating.
Let me, if I ramble, just stop me. But
So here's the story. A long time,
in the 1940s and early 50s,
Johns Hopkins launched something called the Precursor Study, and all of these graduating medical students
1,337 students
signed up.
between 1948 and 1964.
And every one of them agreed to be poked, prodded, examined up and down,
You know, their blood pressure, their weight,
asked all these questions.
their habits, how much exercise they took. They did Rorschach ink blot tests.
Wow. And what was the point of the study? Well, originally it was just to pinpoint the precursors to heart disease, but over time, the study went way beyond that, and the researchers started asking all sorts of other questions.
Questions about depression, anxiety,
50 years of this study, and the doctors are getting older and older, and
support, retirement.
at a certain point, about 15 years ago, Joe and the other researchers started to ask these doctors about death.
So if you have that paper in front of you,
Yeah, hang on. Essentially what they did was they presented the doctors, many of whom are now in their 60s, 70s, and 80s, with the following scenario.
scenario is there.
It says, and it goes something like this. So say you have brain damage or some brain disease that can't be cured, you can't recognize people, you can't speak understandably, and you're in this condition for a long time.
Like brain dead.
Well, you're not brain dead, but it kind of describes maybe a scenario that's like severe dementia.
And then it says, indicate your wishes regarding the use of each of the following medical procedures.
There's a list, 10. CPR, IV fluids, major surgery.
There's a bunch of them. So the question they're asking is, if I'm in this terrible situation, would I want these things? Would you agree to have these things done to you if it came down to it?
Right.
Okay. So what would you say as an example?
You're asking us now?
Yeah. And I also put the question to a bunch of people on the street.
So my name's Sean Full, I'm a reporter with.
Well, give me one.
So CPR, for example. So your heart stops CPR. Would I want CPR?
Yes.
Well, yeah, I want somebody to do that.
Yeah.
Sure, yeah. Yes.
Oh, yes.
Seems like a no-brainer. What about mechanical ventilation? It's a breathing machine.
A breathing machine.
You're gonna die if you don't get it.
Well,
Maybe.
Then yeah, okay.
Yes.
Yeah.
Yeah, I would say don't do it, yeah.
Kidney dialysis.
Dialysis.
Yeah.
Yes.
right, so.
Feeding tube,
Yes.
Yeah.
major surgery.
I don't know.
Like a gallbladder operation? If we're just talking about gallbladder.
Sure.
Yeah.
Yeah.
Antibiotics.
Yeah,
Totally.
Sure.
sure,
IV hydration.
yeah.
Yes.
Yes,
We
please.
would want all that.
Yeah.
Yes. That's what most people say. They want most everything. Maybe not some of the super invasive stuff, but generally, yes. Okay. On the other hand, you ask the doctors what they want, same situation. Brain dead or brain injured, whatever. Do they want CPR?
90% say no, they would not want CPR.
Really?
No, yeah, and I asked a bunch of doctors about the health conference here in New York, the following medical procedure. They said the same thing. CPR.
So no CPR.
No.
No CPR.
And almost 90% wouldn't want ventilation or dialysis.
Definitely not.
80% would not want surgery.
No.
80% would not want invasive testing. Almost 80% wouldn't want a feeding tube.
What?
No.
Or blood product.
No.
Antibiotics, 60% say.
Not really.
IV hydration, about 60%. And then they don't.
Oh, they know.
And then pain medicine is the one that's a bit different.
The actual item on the survey reads, would you opt for pain medications even if they dull the consciousness and indirectly shorten my life?
There, 80% of them say,
Yes. Yes. Yes.
Green would be my yes.
Absolutely. Yes. Yeah.
Yes.
Any medication, yes.
So pain medication that's all they want?
For the most part, yeah.
Why is there such a big gap between doctors and patients? In terms of how they want their blood? Yeah.
Well,
Hi, is it you? Great to meet you. How are you doing?
it started to become clear to me when I talked with Ken Murray. He's also a doctor.
And you're in your Dr. White's here?
I thought I'd impress you.
I met up with him at a hospital in Los Angeles. He's written a bunch of articles now about how doctors want to die.
This exact question was asked.
So I asked him, like, why is there this difference, you know, particularly with something like CPR? What is it that doctors know that we're not aware of?
Well, we know that CPR is basically pretty terrible as an intervention. It basically doesn't work very well. And people just don't believe that. They just can't believe it.
And for very good reason. There was a study done in 1996 about how many people survive CPR intervention on ER, Chicago Ho, Rescue 911, 96, those are hot shows then. And so the researcher watched all of these medical dramas.
And recorded what the result was.
Come on, you can do it. Come back to us, Don. Do it. Come on. Do it.
And the answer was 75% of the time, people
Okay, get the oxygen.
were revived. It worked 75% of the time.
Easy breath.
The actual number is more like 8.
8%? Roughly 8% survived to at least a month.
And in fact, it's worse than that.
Here's how that 8% breaks down.
When you actually break it down, it was a fellow who did a study in 2010. He looked at 95,000 cases. Actually more than that. I think it was all the cases in Japan that year. And what he found was that about 3% had what you would call a good outcome. That is, return to a meaningful quality of life.
You and me sitting here talking and eating sandwiches.
Exactly. About the same number
3% or so.
ended up in a chronic vegetative state. Not quite brain dead, but pretty close.
And the final 2%,
Were in some sort of intermediate level. Not good, but they weren't comatose. Everybody else was dead. That's the reality of it. And we physicians, we know that. We've actually done CPR. We have actually laid hands on the chest.
here's something I didn't know. Ken says that when you do CPR, you often end up cracking a person's organs. And yet that, according to Ken, is kind of mild in terms of some of the things that doctors put patients through.
I think a lot of times we're doing things to people that we wouldn't do to a terrorist.
Is that true or is that overstated?
I'm not kidding.
Like what kinds of things?
Well, paralyzing somebody so that you cannot move, which you generally have to do when you put a person on a ventilator, a breathing machine, a respirator. When you put somebody on one of these machines, it breathes for you. But the problem is you'll fight because you'll have your own rhythm. So what happens is you have a person that is fighting, and you can't get air in and out of it. So you paralyze them.
So they can stop fighting. You know, they can't move.
But it doesn't mean they're asleep. They're not asleep. They are completely helpless. And yet they're aware of everything that's going on around them.
It just sounds nightmarish, actually.
Yeah.
Ken took me through a bunch of different situations, from congestive heart failure to lung disease and pancreatic cancer, where he feels basically that the treatment is worse than the actual disease, what you have. It may be prolonging, but not for very long, and the life that you have left is misery.
Right.
In fact, Ken says that colleagues of his, other doctors,
They'll turn to me in the ICU and they say, if you find me like this, kill me. And they're not kidding.
he says there are doctors who wear medallions with the words "no code" stamped on them, which just means "don't resuscitate me." He's even seen tattoos that say "no code."
Okay. Can I talk to you now?
Yes.
Do you have any idea? Come on, you put that off. All right, Sean, can I just break in for 1 second?
Yeah.
Because while you were reporting this piece, a very strange coincidence happened to me. I was visiting my dad, and after dinner one night, he sits me down and he says, I have something important I want to tell you. I've signed an advanced directive. Basically means if I end up in the hospital, terminally ill or something, I don't want a lot of medical stuff done to me. I had not told him about your story at all.
Really?
Yeah.
So it's just out of the blue.
And he shows you a piece of paper, or?
No, not then. But I just saw him a couple days ago, and I asked him to read it to me because I hadn't actually seen it yet. What does it say?
I direct that medical care be withheld or withdrawn, and that I be permitted to die naturally with only the administration of medications. I authorize the withholding of artificially provided food, intravenous fluids, and other nourishments.
If I cannot give direction regarding medical care, I intend that my family's physicians honor this declaration as the final expression of my legal right to refuse medical care and accept the consequences of that refusal. Huh. So pain medication is all you really want.
Yeah. Keep me comfortable.
So, looks like some baby's crying. So it sounds like, why would you want artificially provided food, intravenous fluids, or other nourishment?
That's my choice.
Yeah, but that doesn't sound like it's that much of an intervention.
It is an intervention to sustain life unnecessarily. If I should ever have a terminal condition,
Would you want CPR done?
if I have a choice, the answer is no.
But wouldn't you want mom or I to be in a position where we can make the decision?
I mean, what if you conflict?
Like, she feels one way, I feel another.
Yeah.
He told me this is one of the worries that doctors have, that they'll talk to the patient or the patient's family, explain the situation carefully, everyone's agreed, no more interventions. But then a random family member will just show up, like a cousin or an estranged son or daughter, maybe carrying a lot of guilt. And they're like, no, doc, you have to do whatever it takes.
At the end of the day, I give the option to the patient and to the family to make a decision. That's what I have to do.
Except in this case, when the patient is him. But by having this, it means we have to honor this, right? We can't have our own feelings about it.
You can have your own feelings, but you still have to honor this.
But it's just, the thing that gives me pause is that, I mean, you're a doctor, your job is to prolong life and to sustain life. And you choose not to when it comes to your own life.
Nobody said my job is to sustain life. My job is to sustain life when it is possible. It is not to sustain life when it's futile. And if you're going to sustain my life on a respirator, I don't want it. That kind of life I do not want.
More than anything, the thing you want to make sure of is that he does not die in a hospital. He definitely does not want to die at the place where he works.
That's something that came up a few times among the doctors at the conference that I went to.
I think I don't want to die in a hospital bed.
This is Tim Ryan, a resident at Cleveland Clinic.
Why not?
Because I see patients and patients' families suffer tremendously, and I think we do a poor job of communicating futility to them. I don't know how to communicate that effectively. I don't know how to do it better. It's a difficult thing to bring up to the family. How do you tell them your grandfather is not going to get better? We can keep him alive for a few weeks or a few months, but he's probably going to have a tracheostomy and a feeding tube, a catheter in his bladder, and then he'll get bed sores and slowly deteriorate. I think we can focus on, extending a life that has some quality so they can interact with their family, but once that's gone, I don't know that we do much benefit.
It sounded great. That was perfect. Why didn't you say that?
I don't know. You have to have a sense that people want to hear that.
Well, no one would want to hear that.
They
would need to hear it.
But it's a little bit presumptuous.
You can't tell someone not to hope. You can't pressure them to just let go of their love. And obviously you can't refuse to provide care.
There is one thing that struck me that talking to my dad. There's a question that patients will sometimes ask that can be a kind of bridge between doctors and patients. Very often, he says, when people are in the middle of this decision, they'll turn to him and they'll say, Doc, what would you do if this was your mother or father? And he says, when they ask the question that way, it creates an entirely different conversation. He can say, here's what I would honestly do. In fact, I did not know this. Here's what I actually did.
It happened with my parents. When my father fell and developed complications as a result of the fall.
He says he called the doctor and told him no more medical interventions.
And he ended up dying comfortably. Same thing happened with my mother. I had discussed it with my mother and my father when they were not not sick. This was a plan. I can tell you in 9% of the patients that I see, such planning doesn't happen.
I had a habit for most of my career when I had a new patient come in, particularly over the age of 50, I'd ask them, how do you want to die?
This is Ken Murray again.
You know, a lot of them, you know, would give me kind of a funny look. That's an odd question for a doctor to be asking me. And I said, well, you know, it's the one thing we can be sure of that's going to happen eventually. And I want to make sure it happens the way you want. And so people, you know, the typical answer is, well, I'd like to die in my sleep, you know, painlessly.
The fastest way without any pain.
Peaceful without pain, that is Frank's.
Which is how most people answer the question.
Doctors and non-doctors.
With the least amount of pain and not drag it on.
Swiftly and painlessly.
But what is that? What actually is that? That's usually a heart attack or stroke, something of that nature, that happens just like that, and you're gone.
And that's what we and our doctors are essentially doing everything in our power to avoid. So like when you ask people in the abstract, they're saying,
How do I want to die? Peacefully.
I want to die peacefully, I want to die in my sleep and everything like that. But when you ask them the specifics, you hear,
No.
pound on my chest, stick a tube down my throat. So it's this paradox.
Well, it sounds to you like a paradox. Just think about it. It could be. It's so healthy to do both, even at the same time. It's healthy to want to stay, and it's healthy to know how to be ready to go. I was listening to a Fresh Air sort of retake, and they had Maurice Sendak on here, who died not too long ago. Before he died, he was on Fresh Air.
It's an amazing interview.
Yeah, and Terry Gross was talking to him, and he's sitting there in his Connecticut house looking out the window at a tree. And he says to Terry, I am so in love with the tree and the beauty of it and my chance to keep it company just a little while longer. And I want to stay. And every extra day I get is a day that's precious to me and makes me want to stay even harder. But, he says to Terry, I am ready to go when it's time. I've made myself ready.
Mm-hmm.
And that compromise you make with yourself, to love it with your whole soul, and yet at the same time say, I'll know when it's over, and I'm composed enough and prepared enough to take my exit. That's what a good death is.
Thank you, Sean Cole.
You're welcome. This is Sean Cole's, I mean, he's not his last picture, but this is the last time he's on a full paycheck.
Yeah.
He's going off to host many things and be recorded at other places.
Yes, it is a kind of death, really.
Yeah.
It's nothing
A
like
good
the
death,
kind of
though,
death.
would mean, Sean, that you come back here regularly.
I will haunt you all.
You better. Special thanks to everybody at the UV Symposium on Vascular Health.
And to our doctors in this case, Joe Gallo and Ken Murray.
I'm Jan Rod.
I'm Robert Goldwich.
Thank you guys for listening.
Hey, this is Glenn and Rand and Reagan. We're listeners from San Marcos, Texas. Here we're going to read the credits from Radio Lavison.
So of course, to make anything good, it has to be a little bit dramatized and have a very unique view. And I think that that's a lot of what happens in this Radio Lab interview, is that if this is one physician that has a really unique view and is willing to go out on a limb and express that. And what we want to really look at is that we all probably have our own views on that, whether we're providers or not. And to sort of have the opportunity to ask different physicians what their points of view are. So this isn't a judgment in any way, but just a way of saying, let's examine that and see what that looks like for us. So I just want you guys all to be aware that that's really what we're thinking here, and then look at yourself and think about how that will be for you. So it's a learning opportunity to have a conversation around that. So, I don't know who wants to jump up first. You can arm wrestle for it.
I can go.
Go for it.
Okay. I was, I was sitting kind of brainstorming about this earlier, and I came up with probably no less than 50 different reasons that physicians think differently about this than the rest of the general public. And I'll try to rein myself in a little bit. I had heard this podcast a while ago when my wife and I were driving back from somewhere, and I didn't find this surprising at all, actually. And to a certain degree, I think this sort of the more interesting, so the question of why physicians feel the way they do is kind of less interesting to me than the question as to why physicians come out so differently than everyone else does. And I think the answer to that question is, well, I think the answer to the physician part of this is pretty obvious. Whether it's in our training or in our day-to-day work, we have tons of exposure to illness, dying, and death. It comes with the territory. And with that comes, for any given patient who's in the hospital under my care, this is their one experience with dying and death, whereas it's probably my 8th of the day. And I think that's going to lead the two of us to different conclusions about things. My take on things is, in a lot of ways, dying in the hospital, for lack of a better word, it sucks. It really sucks. And it is, on a host of different levels, it's an experience that's rife with indignities, whether it's being in one of those ridiculous gowns that have continued to grow in size and barely shield the average patient's genitalia, to having blood tests every morning, which are painful, to spending a great deal of your time delirious and confused, to having strangers in and out of your room at all hours of the night, being deprived of sleep, being fed crappy food, sleeping in an uncomfortable bed. All these things, any one of them may sound a little bit trivial, but if you look at the sum total, it's awful in a lot of ways. Now, I don't want to say any of this to sort of trivialize any one person's illness. People are in the hospital for good reasons in most cases, and they're not to be blamed for being there. It's fully understandable, but the experience has a lot of negative sides to it. And it seems perfectly reasonable for me as a physician to not want to go through that myself, and I frankly don't. I can say with confidence, I want to die at home. I do not want to die in a hospital. I do not want a prolonged illness where I'm stuck going through what a lot of my patients do on a day-to-day basis. So I think, if any of you were able to, so the guy that we're interviewing on this story he had a story that was posted online a couple of years ago. The link was on the website. It's a fabulous article. If you haven't tracked it down, I would recommend it to you. He sort of breaks this issue down into sort of 3 categories, and I sort of jotted up a number of items under all of them. So if you think about why do patients think about this differently than physicians, I think there are patient factors, there are physician factors, and then there are kind of system, cultural factors, and just a few items under each of these. So let's start with physicians. How can physicians claim some responsibility for the way that the average American dies, which is in the hospital after a prolonged illness? Well, number one, more and more, when one is admitted to the hospital, one is being cared for by physicians that don't know you. Right? It used to be that your doctor took care of you in the hospital, and that model has been largely abandoned. I'm a hospitalist. I care for patients I don't know almost exclusively. So very clearly something is lost, right? The relationship is lost, and we have to sort of start from scratch when we start caring for patients in the hospital under these circumstances.
That is my biggest grief with the American healthcare system right now. We make this big thing about be sure and talk to your doctor about your end of life wishes. Your doctor isn't going to even know you're in the hospital. Well,
right.
It's really scary.
I think it's the number one downside to the model we've adopted, where we have this sort of divide between the hospital world and the outside world, or the hospital world and the sort of office-based care world. Some other physician factors. whether you guys know it or not, we're under enormous pressure to please our patients. So a sort of consumerist model has been adopted wholesale by the healthcare system. We get feedback on patient satisfaction. These surveys are given out to patients all the time. And very interestingly, on a side note, there's a study that was recently published that actually showed that patient satisfaction, higher patient satisfaction is associated with poorer outcomes. So, so the more pleased your patients are, the worse they're probably doing. And it's very interesting. But you can, if you think about it, you know, in our sort of, in the pressure for us to please patients, some of our defaults and our biases really shine through. And I think one of those biases in medicine on the part of physicians is when in doubt, do more, don't do less. And this grows out of a number of things, but you know, from the early days in our training, we are punished and castigated far more for errors of omission than errors of commission. So if you miss something, that's the worst crime in medicine. You don't miss something. You know, you can overdo it, you can get a diagnosis wrong and sort of give people treatments that may not have needed, but if you miss something, that is the worst you can do.
You get sued for it.
Right. And it grows out of fear of litigation, but it's also even it's built into our training. You know, there are these sessions called morbidity and mortality, where they're sort of legendary in medical training. But you sit down in a room full of your colleagues, and a case is reviewed, and the person who screwed up, who missed something, sort of takes verbal punishment for that.
Are these real cases?
Oh yeah. It's a real thing. Another part of the physician piece of this is that historically we've been really poorly trained in communication, and you know, if you all think about your experience with the doctors, we don't do a good job of communicating prognosis, among other things. More and more there are tools available to help us actually get people a number. You have this disease, your life expectancy, or the probability of you surviving 5 years is X. That data is out there. We don't do a good job of communicating it. But beyond that, it's just hard for us to talk about the idea of someone dying sometime soon. It's not comfortable. And again, when we don't know our patients well, it's even harder. Those are some of the physician factors. A couple of patient factors here. Number one is expectations. I think in a lot of cases, patients, especially patients of advanced age and who've had long-term illnesses, have somewhat unrealistic expectations about what the healthcare system can do. Now, this is not malicious. This is not out of it's not ignorant or anything like that. I think in part it's a product of the successes of the healthcare system. You know, so modern medicine and public health have had amazing successes in the 20th and the 21st century. We can cure diseases that we never could before. What's up?
Prevent them too.
We can prevent them. Life expectancy is as long as it's ever been. That being said, there are still plenty of things that we can't fix. Plenty of problems we can't fix. We haven't solved the human mortality problem. People still die. The mortality rate in the population is still 100%. But you know, I think it's easy to think that, well, physicians were able to fix my problems up until this point. They should be able to fix them now. And people do reach a point in their health where those problems become unfixable. Another issue is that many of us have not given much thought to what kind of care we want if we became terminally ill. This isn't surprising to me. It's not pleasant to think about. Most of us are not familiar enough with disease and illness to even know where to begin. And again, back to the communication piece, this is not something that physicians are talking with their patients about on a day-to-day basis. It's just not part of our normal everyday conversation. That's where sessions like this are good in sort of spreading the news about this kind of thing. We have a long way to go. The last patient factor is, I think, you know, who's watched Breaking Bad?
Oh yeah.
So think about the first season of Breaking Bad. Walter gets this cancer diagnosis, and he basically tells his wife he doesn't want treatment. And what happens? Anybody remember?
Yeah, his wife freaks out.
Yeah, they have an intervention. So Skylar and you know her sister and brother-in-law all sit down around their family room, and basically Skylar talks them into getting treatment. Well, I think there are a lot of situations where a patient, him or herself, is sort of ready to accept that the end of their life is near. And under the influence of family members, their thinking changes a little bit, and it's relatively common. It's not every case, but it's another factor that contributes to the idea that the average person dies or prefers to die a little differently than the average physician. And there are thousands of other factors. A couple others, and the main one I wanted to touch on under the sort of system and culture issues is the way we talk about illness and the way we talk about death and dying in this country. And I think this may be a little controversial, but I would submit to all of you that the sort of how do we talk about illness? What are people doing when they have an illness? I mean, can you think of any words that are used commonly?
They're isolated.
Well, let's think of verbs.
They're fighting it.
They're fighting an illness, right? So our talk about disease in America is riddled with martial battle terminology, and I think this is a giant disservice to all of us. This language drives me crazy. I think it grows out of a sort of authentic place. I think it's well intentioned, but I think it's ultimately destructive. So when we talk about cancer, for instance, anyone with cancer is automatically in a battle, and I think that's fair to some degree. It's certainly,
And even more, they're heroic.
right. There's heroism packed into it and everything else, and I think there is a lot of bravery. There's a lot of perseverance that goes into accepting the treatments for an illness. But I think the metaphor starts breaking down when you start looking at the details. Is someone really battling their cancer? Are they throwing punches? Are they shooting guns? No, I think treatment for an illness is often a very passive thing. You're sort of this vessel upon which tasks are performed. And the part of this that I take exception with most is what happens when someone decides not to get treated anymore?
They're giving up.
Are they a coward? Are they giving up? You know, and I think that's, I think it's a disgrace to even suggest that someone is not being brave, is not being a hero or whatever it is, if they change their mind about wanting treatment. I actually think that decision is among the bravest there is basically in the human condition. And so I really try to avoid this battle language when it comes to cancer or any other illness, because I really think it distorts our thinking. And I think this language has had profound negative effects on the way many of us think about illness in this country. So I'll shut up now and let the others speak, but they're just some thoughts.
I mean, there are a couple of things that I wrote down here. When you're talking about that patient survey where the increased patient satisfaction is correlated with a decrease in their health outcome, I saw another study that was similar that was increased patient satisfaction is directly correlated with a decrease in lawsuits. So if a physician made a mistake, if you had a good relationship with him, you're so much less likely to sue them. Right? So that's like a double bite in so many ways.
Totally, but one way of pleasing your patients is to give all of them a little bit of hydrocodone. So there are ups and downsides to this, for sure.
Right.
And also, which is cause and which is effect. People that are really sick are grateful to the doctors when they survive.
Right.
So they're satisfied.
Yeah.
I mean, the other people going around to answer the questionnaire.
It's a great point. But the point is, it is not necessarily the case that pleased patients are healthier patients.
No, absolutely.
Right. Well, and the other thing that I find that is so salient to me working in hospice is, I think for 20 years, the hospice model of marketing or education is to go to the providers and say, talk to your patients about death, like help them understand this piece. And I think, I met with a girlfriend of mine today that's going to meet a friend of hers who is at the end of her life, and she's coming to me to say, I don't know how to talk about this. So it's not a physician thing, that is a human thing. Nobody's comfortable talking about it. Well, in our culture, nobody is comfortable talking about it. And I don't think that that's right to put all of that in someone else's hands. That's our responsibility to be asking those questions, to be talking about it also. And so that is very true. It is uncomfortable, no matter who you are.
Right.
And so I think that we can skirt around that a bit and talk about it ourselves. That's the bigger question when he said, I would ask the physician, if this were your mother, what would you do? This is what I want. It's a different sort of conversation then.
I love that question, by the way.
Mm-hmm.
I'm trying to be more honest in my answers to it. And I think it is, they mentioned the word, this can be the bridge to sort of taking things in a different direction, it really is. My experience has been that's when the conversation gets really good.
Well, I'm asked that all the time. I'm learned, I just give them the exact honest answer. That, but, say that every situation is different.
Right.
I mean, just give an example, an extreme example, I give often to my patients. You know, I often counsel patients, look, we shouldn't even treat your cancer. You're frail, you're old, we're gonna make you sicker. It's not gonna help you. But there's one patient I had, an extreme example of old and frail and sick, 85, bad health, bad cancer, couldn't really treat it well. And I said, sir, I don't think I should treat you. The chance of my making you worse is vastly higher than my chance of giving you any more good life. He said, well, doc, I hear what you're saying, it's exactly what you're saying, but I need to be alive on August 15th, 3 months from now. And I said, well, now, if we were to do that, we would have to treat you very intensely, probably keep you in the hospital, you're going to be absolutely miserable. He says, I don't care, I have to be alive on that day. And I said, well, why is that? Well, I have a life insurance policy, and that vests on August 15th. If I'm alive on that day, my family is set. If I'm not, they're not. So.
No pressure.
Right.
Yeah, just make that happen.
So, I mean, you know, that's basically, that was his wish, and that's the way it should be. And, you know, we treated him. He was in and out of the hospital. He was on a ventilator once. He came off of it. And on August 15th, he was alive. He said, Doc, I'm done. Stop all my treatment. I'm going to go. He died the next day. And he said, I'm going to die a happy man. So that's the extreme example. I mean, but, you know, often it's just the other way. I say that, you know, it's time to stop treatment. Basically, thank God that you're telling me that. I'm ready. And it's often in between someplace.
The interesting thing to me is how much control people have over when they're going to die. If there's something, you know, they want to be at their granddaughter's graduation, it's amazing how often they can make it. It's, we think these are sort of random events, but there's so many factors involved.
The other thing about trying to figure it all out ahead of time, and doctors try to do that, is how often when the crunch time comes, it's not that way at all. I don't know how many patients have come into my office saying, Doc, I thought I'd never be here. Like, I always told everyone, if I ever get cancer, I'm not going to take chemo. So they walk in and say, well, here I am. I'm ready. And, you know, I've had many docs say, you know, I've treated doctors, and they come and say, you know, Pat, I never thought I'd come in here, but here I am. I mean, when it's your own life, not just some patient that, you know, you care for, but it's not you. I mean, it's very different.
There's a folk saying in Spanish that you hear in end-of-life conferences once in a while, which says, translation is approximately, the bull looks different when you stand in the ring.
Yep.
Yeah, I think that though, you know, I like the idea that it is a brave thing to change your mind too, right? Because I have my own ideas about what that will look like, and when I'm in the ring with a bull, they might change, and then 2 days they might change again, and I want that freedom to do that, and I want the support of the people I love to do that, and not to feel that that's a failure or that I've given up or that I've lost the fight. You know, I want to say, great, for someone else, and say, I want that in return, you know, to celebrate those things for me, because it is a difficult decision. But we sort of do that about everything, right? If you change your mind, you like waffle, you're not super firm on things, like there is a weakness even associated with that. So imagine how much more compound that becomes when you're talking about end of life, you know? You don't want to change your mind, I'm going to do this no matter what. Like, that's not reasonable.
That presumes that you've given some thought to it.
Right.
So many people haven't given thought to it. I remember sitting after one of the Friday morning medical conferences at the hospital and seeing my own physician at the back of the room, and I sat by her and I thought she'd want to talk about what had just transpired. But what was on her mind was that it just felt so heavy to her, the hospitalist idea, the fact that she wasn't seeing the people that she knew in the hospital anymore, and that people were burdened in her mind with having to know so much about what they might face, and to not feel like they could actually say to their doctor that they know, what would you do?
Right.
So it would be great if everybody had the time to imagine the what ifs. What if I have this? What if I have that? But that's a lot of thinking and a lot of knowledge to accumulate that doctors have.
Well, and I think this radio piece is right on. That I have had to talk to a lot of prisoners over the last 15 years about what did they want us to do when they got to the end, you know, and they have no conception. You know, you're trying to talk to them, well, do you want us, you know, you don't really want us to be on your chest and break your ribs and put you, you know, and, oh yeah, I want you to do everything, doc. And you can explain it over and over and over again, but if you've never seen anybody on a ventilator, you have no clue how inhumane it is. I mean, if you got something that you gotta be on the ventilator for a couple of days till you're better, that's one thing, you know, but the end of life ventilation thing is terrible. And to convince people who have no experience of it, what you're talking about, is really hard. My biggest fear about dying, I don't have any particular fear about dying, I've had a couple of very near-death experiences. My biggest fear is that I'll end up in a car accident or something, and you're gonna start doing things to me, and my kids are all over the country, and, you know, all of a sudden, things are happening that, and I've got all the end-of-life documents and the choice bank and all that, but who's gonna know? I'm young, healthy, you walk, I mean, it's really hard. And people don't understand, you fill out all those documents, but if you are in a car accident, everything is going to be done until somebody figures out what the prognosis is, you know. People think, well, I signed a DNR, they're not gonna do anything for me. Well, you know, most of the time, they are. And that's hard to explain too.
Or going into surgery.
Yeah.
Most people don't know that when you go into surgery that the DNR goes away while you're in surgery.
Well, you shouldn't go to surgery for DNR, maybe.
Well,
that's another, yeah.
But if you go into surgery for a gallbladder, you know, I think that it depends on what you're in surgery for, right?
It's the ethics of that situation remain unsettled.
Right,
But
because
it's,
who knows what's gonna happen when they get in there,
Yeah.
who knows, I mean, there are so many unknowns. It's too bad you can't just have a full body scan every time you walk into the hospital,
Well,
like, sorry, 2 months, don't even
You'd
try.
think if you were well enough to go in for surgery, somebody would think you were well enough to come out of surgery.
well, no, see, what I see is people who, you know, whose doctors come in and say, well, of course we're gonna try and give you a new heart valve. Or of course we're gonna try and go in and put a stent in your kidneys. Of course we can do this, you know? And they don't go into what the possibilities of it not working.
Oh, yeah.
Or the probabilities of it not working.
Yeah. And people sign consent forms that they have no clue what's on them.
Oh, yeah. I remember talking, I'm a chaplain, and I remember talking to a woman, and she's 92. And she was going to go in for heart surgery. And I said, now I see on your bracelet that you have a do not resuscitate. And she said, yeah, I don't want to live on a machine. I said, well, you know, when you go into surgery, that goes away while you're in surgery. It does, she says. You know, I don't think people are educated. I think it comes down to communication in a lot of ways.
Yeah.
Yeah, that's true.
It's not, probably, it's so much more complicated than the general public realizes.
Oh, yeah.
I mean, I was thinking, 92-year-old getting a heart valve. Well, I remember very good, I have a 92-year-old patient. She's got a blood disease. It's probably not going to be what takes her away. She had a bad heart valve, and she couldn't walk across the room without getting short of breath. So she went to the hospital here, and they put a new valve in through her groin and fixed the valve. And she said, my God, I'm a new person. I can walk around the block now. I can take the dog out. I can do all these things I couldn't do for years. Was that worth it? Well, darn right it was. I mean, she sure thought it was. I mean, if you make the 92 and you're kind of okay otherwise, you got a little bit of momentum going there. And people are less likely to die if they're doing okay at 92 than someone sick at 62. I mean, they've somehow got it right. You know, the whole thing about, you know, they talk about how the general public, God, I want CPR, you know, 8% risk. Well, if someone on the street falls over and dies, you know, stops heart, heart stops, they probably are a little bit better than 8%. They got to, you know, they're defibrillating. You just fix that and they might be okay.
If you got an AED.
Yeah. Right.
Yeah. Or if you live in Seattle.
We live in Seattle.
Yeah.
Or they have those things all over the place. So that's kind of a little bit different. Of course, they see it on TV that everyone knows well. But it's a matter of education. I mean, I'm an oncologist. I mean, I'm not like Tim. I mean, he sees a patient the first 8, 12 new patients a day that he's never met before.
Yeah.
Well, every patient I see is someone I've known, often for years. So So I know these people, and they know the diagnosis, and virtually every one of my patients who I call terminal, you know, is that don't do the CPR, don't do this, don't do that. They've got it all figured out, and their family knows it. And the only red herring is what you were talking about. You know, here's the black sheep of the family coming in saying, "What the heck? You're not going to give my dad CPR? What the hell? I'm going to sue you. I'm going to take it. I'm going to pull out a gun and shoot you if you don't do it." You know, seriously, those things happen. It's the family member you haven't seen in 50 years, 30 years that comes in and throws a wrench in it. But in the hospital, I mean, you know, the people in the hospital that worry about liability, they're telling docs, "Oh God, you got to do it. You can't. It doesn't care. It doesn't matter what the patient said. Or what 95% of the family says. You got to push it on everything."
Or the keep my dear mother alive until I get there day after tomorrow. I mean,
that I can deal with, and sometimes
I can too, but it's not.
But you're right.
The gentleman in the back has a question.
Do you find yourself refereeing between your patients and their families so that they can have those conversations?
Yeah, sometimes.
But yeah, I'm thinking particularly his, because it's chronic and generally the statistics.
You know, when I first meet a patient, if they have a diagnosis that I know I can't cure, pancreas or lung, or, I say right up front, we are not going to be able to cure this. We will not be able to make your cancer go away. Our job is to keep you feel as good as you can for as long as we can, and that's the best we can offer. So they all hear that. There's usually all the families there. Now, what I find is the patients almost never hear that. That's why I always like having the family there or someone there, because maybe a nurse will ask the patient, "Well, what did Dr. Beatty tell you?" He said, "Oh, I've got that. I'm going to be fine. I'm going to be okay." Well, no, I didn't say that. But they're shell shocked. I mean, they just been told the most horrible thing in their life. You have cancer, you're gonna die. They don't hear it. So it's you can't have that conversation. I mean, I was talking to my significant other, who Rita's mom, and she said, "Well, Dr. Pat, why don't you just have these hospice conversations when you first meet them?" I said, "Well, patients won't get it. I mean, they just don't get it. They can't get what hardly anything I say. And I'm really talking beyond them to the family members, so they'll hear what I say. And I try to get to them eventually. Or they'll come up and say, "Doc, how much?" 3 weeks later, say, "How much time I got left on?" I said, "Well, I can't tell that with anyone, but with you, nothing else gets you. It'll be cancer that's going to get you, and it's going to be, within a certain time range." So it's having the conversation. You got to do it at the right time, not when you first hear something that's going to change their life forever.
Well, cancer has such a bad PR rap.
Well, it does.
People hear the word, no matter what kind of cancer you have, what the prognosis is. I mean, we do pretty well with some cancers now.
For some, and
yeah,
keep people going, and congestive heart failure, brittle diabetes, strokes. I mean, they're worse than cancer.
Oh yeah.
The cancer is definitely the scariest way.
Exactly.
Yeah, they hear that word and it's you can't say anything more. Yeah.
We had a doctor here in a conversation that said that would be his preferred choice, to get cancer, because that would give him time to wrap things up and do the things he wanted to do.
Depends on what kind of cancer.
Yeah.
Yeah.
I don't like a pancreatic.
Question in the back?
I was just thinking if the conversation, it might be helped, especially if the family and the patient are using I just learned about a data point that's used in epidemiology called a quality adjusted life year. And instead of giving people a prognosis, it says, with this you can live for 5 months, or with this you can live for, or without this, or with this you can live for a year, without this you can live for 5 months. You really start to talk about you live for this quality of life with this, and you live this quality of life with this plan. And it's basically, if a quality of life, a quality adjusted life year is like, if you're in perfect shape and you are going to live a quality adjusted life year, you get a year, a 1. If you have got cancer, then you might live a year, but your actual quality adjusted life year is a 0.3, because you're going to have cancer during that year. You're going to suffer. Your life is not going to be a full quality. if you have cancer and you get chemo, maybe your life quality could be below zero. You're better off. I know this sounds callous, but it just levels the playing field if you start to talk like this. Your quality of life is less than zero if you're getting chemo and suffering even more than if you're getting just cancer. And that helps to, if you can start to talk to patients and families like that and say, you know, with these different options, this is how the quality of your life is. I just think
But it's
that
all relative. Every patient is different, how they experience. Some patients, I have a friend who's having chemo right now, and she's deathly ill. I've had patients who, identical regime, and they get up and go to work in the morning.
Sure, I think you're talking statistically.
Yeah.
You know, you're not talking your situation, because you can never say that.
Yeah.
You just say statistically, if you do this course, then your quality of life is not a 1, it's going to be, because your 1, that was another time. You have cancer, your quality of life is a half.
No,
I think it's a good reason.
But I just think if you start to communicate with family members like that, say CPR, okay, great, we'll give your family member CPR, but just realize we're bringing him back to less than zero quality of life. I know, again, it's so statistical, but it just makes a language that if people are willing to adopt it, then.
Well, it's a term that's used in research quite a lot now. I don't know that it has any efficacy in daily communication.
Yeah, I think it's a tough concept. I mean, I know exactly what you're talking about, and I totally believe it. I mean, just to give you an example that, you know, there used to be a treatment we used routinely for metastatic malignant melanoma, one of the worst diseases. It's called high-dose interferon. And there were studies that show that it could prolong life about 6 months. Well, the treatment course usually runs a year. And during the whole treatment course, you feel every minute of your life that you have the worst case of flu you've ever had.
Right.
And I tell my patients, don't do it. I mean, you know, I can keep you alive for longer, 6 more months, but you're going to wish you were dead.
Right.
So I say, I don't recommend it, I don't want to do it. I've given it years. I can almost always talk people out of it.
But that's what if you've been.
But sometimes, but you know, people have this fear about chemo, that it's always going to make you real sick. Well, there's some patients get better. I mean, patients who have, for example, small cell lung cancer, it's a fatal, absolutely fatal lung cancer. A lot of times people come in with one lung has been deflated because the cancer blocks the lung. But if you could open that up, and usually we can, often can, well, gosh, they feel better all of a sudden. So they're in a situation where they would be dying within a few weeks horribly, or all of a sudden literally get a breath of fresh air, and they can maybe live another, 6 months. And like you're saying, they have time to get their affairs in order. So, everyone's different. I've had some people come in and say, my life sucks, I don't do anything, I'm done.
And I think that your idea about quality of life changes.
Yeah.
My quality of life right now, it would be so much different than someone else who is, struggling with a cancer diagnosis but enjoys the beauty of just being outside in their yard and seeing their kids play. Even if they, sleep all the time and they have no energy and they might be in mild pain. Right now I might say heck no, if that was gonna happen to me, call at the end. But for them, it didn't happen overnight, it happened over time, and their idea about quality of life changed. And I feel like that's something that we fail to recognize when people say, I changed my mind, I still want to continue this treatment, because as that has happened over a progression, what they thought was quality of life is different. And we have to be flexible in hearing that. I get it, it's going to change and that's okay.
I think that's right, but people, when they start to think like this, then they might say, my quality of life will be better. And they have to make their own equation.
Right.
Just to talk to them in these terms, let them make the equation. Let them say, you're right, it's going to hurt, I'm not going to like it, it's going to suffer, but I will be alive longer to enjoy the tulips in my garden.
Right.
And then they make that equation, they figure that out.
Right.
But just talk to them about it.
I mean, I think that we're hearing it's good to set goals and it's okay to change them. You know, I mean, I think that that's pretty realistic. Talk about it, set goals, and what is your quality of life now? Like if I were going to say, you know, I'm okay with having some pain, but I want to be alert, you know, can you do that or not? And then if they say no, I might say, okay, well, I would take a little bit not alert. Like I might change my mind. And to be okay with that. I just think that there has to be a space of gray there. There is, you know, to acknowledge it's big.
I wonder if we knew, I'm sorry.
No, but
if we knew how, you know, like these articles are coming out, how doctors die in this radio lab, I wonder if we knew about those statistics, we being the general public, if things would change for us, if it would open up the conversation, more information.
Or if you were able to see that. Like oftentimes when someone rushes into the ER and they do CPR, they make the family leave. Like we don't get to see that. But let the family see that. I mean, I think that that's a healthy thing to understand what that looks like, and we protect people from that all the time. You know, don't get a chance to see that.
The cynical side of me says, regular folks aren't gonna wanna look at that kind of thing.
Right.
But, you know, in my job, you know, again, I have a real advantage over people like Tim. You know, I can work on people over time, and I can explain, here's what CPR is. You don't want that, ever. You've got pancreatic cancer, even get you through it, it means your heart failed, and it's okay. And we'll get you back, but you're not gonna have a good life after that. And they get it. So, you know, all through the whole thing. I mean, so it's pretty easy, once you know someone and they get it and they understand, you can sit down and talk to them about what these things really are. In a situation it's not just the panic of the moment, they will get it. Like I say, I don't think I've ever had a single patient with end-stage pancreatic cancer who was not a DNR. We just don't let that happen. We think it's wrong.
But it sounds like you have that, you know, you have that continuity. You're able to build a relationship, so you have that trust. And like you were saying, like initially, you meet with the family members because the patient doesn't always hear what you say initially. I mean, you know, I think my own experience, I've had, fingers crossed, really no hospital experience myself, having been in hospital or anything like that, or even in the emergency room. But I have been with friends. You know, recently I spent a day or two with a friend for very long periods of time in the ICU at St. Pat's, and have very little experience of hospitals in the States. What was amazing to me, first of all, was the friendliness of the doctors and the staff, but you Montanans are pretty good at that anyway. I was so impressed with, I felt wonderful just like listening to everybody coming in and out. It was the sheer volume of medical staff that were in, out. This patient, this friend of mine, was in her mid-70s. Her nearest relative was in Seattle, so I was kind of bridging between the doctor and the daughter and stuff. And so there was a sheer volume of people. There was the fact that when people would come in and do vitals and all kinds of things, they're on computers a lot. It seems like people are not all, they're kind of present, but they're on the computer looking for stuff, looking for information, and then you think, that seemed to me a little bit strange because it just feels like they're not there. The other thing that kind of surprised me a little bit, I knew that my friend was quite ill, and she was having lots of tests because of her internal bleeding. We should already have been admitted to the ER the night before. Sometime after, I'd been in the ICU for about 8 or 9 hours at this point, and the doctor came in and said, we're thinking that the bleeding's coming from the bowel, we're thinking we need to take a chunk of the bowel out. And I went, oh, okay. And then he said, because she's had a number of blood transfusions over the last few weeks with different problems, now she's in ICU, she's not going to make it otherwise. I didn't realise it was that serious. I'm not a medical person, I'm probably a bit dim in that respect anyway. I should have realised it was quite serious, but he said she's not going to make it. I said, oh, that was a shock. Then he said, we'll do the surgery as quickly as, within a few hours or something. I went outside to ask him more questions. He was already on the phone. He didn't see me. I overheard his telephone conversation, and he said, we need to get this woman in surgery within the next hour. Somebody on the phone must have been saying, it's going to be a couple of hours, and he said, no, I can't wait 4 hours. And this was, I didn't realise how serious it was. And so I don't know, I could have missed something here. But it seemed to me that medical staff were coming in and out quite a lot. And because they were so cheerful and stuff, there was the impression that it was not quite as bad as it seemed. I mean, I don't know if I'm missing something here.
And was someone trying to get permission to do this surgery from someone?
No, they were just gonna go ahead and do it. They didn't really need permission. It's just that
Well, they did need permission.
Yeah.
I mean, that's. Was she able to say?
Oh, she was able to give,
Okay.
yeah,
Okay.
that's okay.
Right.
But I just, somehow, that when the doctor said she's not gonna kind of make it if she doesn't have it, worried about her making it. I don't know, and I think that, you know, there was no conversation about, well, what are the consequences?
Right. How serious is this?
Yeah.
Why am
Yeah.
I here? And what are you doing right now?
Yeah.
Like asking those questions uncomfortable. You don't understand the language either.
Yes.
Right.
Yeah.
We have a long way to go in terms of, on the physician side, understanding that the average person is starting with even less knowledge than we think.
Yeah.
We assume a certain level of understanding and knowledge that isn't there, and I don't say that to criticize the general public. I say it because medicine is incredibly complicated. It's incredible, you know, and we, sometimes I think that I'm speaking in the, you know, in the simplest, most straightforward language I can, I'm still way over somebody's head. It's really hard.
But I mean, I must say, I was impressed. My friend was, you know, she's moved, she had the operation, she's still in hospital, but she's doing fine. And, you know, the staff are just, they're really amazing. I mean, I felt there was just a real personal touch there from everybody that came in. Or, you know, it was just...
good patient satisfaction scores. Bam!
Yes. Yes. Way in the back. Cheryl.
No, I know that Nancy had a question as well.
Well, just a couple comments and the most recent story. I'm a hospice social worker, and so I think in terms of systems, integrating into the psychosocial personal piece. So I'm thinking about the systems and how they're impacting the conversations that doctors are allowed to have and the time that doctors are allowed to spend with patients, which isn't much, unless maybe you get to a serious disease stage and then you're allotted a little more time, because that's dictated by whoever's paying for the appointment, right? And then there's also a mandate from a larger system that we go to electronic medical record keeping, which is what causes really good nurses and doctors and personnel to look at screens instead of patients and patient family members, because they have to do stuff on a screen because that's how we do our jobs now. So I think about the systems piece, and that, you know, we have to always remember in these conversations that we have to impact these systems. And so we are wanting a healthcare system, big topic right now, and we want to cut costs, but we want every intervention we can have in the last 6 months. And so, you know, we have to start to ask ourselves what our personal responsibility is to the larger system. And, you know, all due respect, maybe I really, really want to live until a certain important date. But what is the larger cost of that? And what is my responsibility? And who's paying for that? And what am I also saying about what the cost of healthcare should be while I'm making those choices? So I just challenge us all to personally look at our political, how our personal healthcare decisions are in line with what we're saying we want and from a larger system. Because I think that puts a lot of pressure on us, it puts pressure on our loved ones, it puts pressure on our providers in ways that none of us really agree with. So I just have to put that piece out there. And then also challenge doctors to provide that hospice information when they're not comfortable to provide it, to go into that zone of discomfort earlier than they think they should, and would offer myself to help with finding the words and to coach it and work with whatever I can do to provide resources or ways to talk to people about that. Because when they come to hospice, they really appreciate the doctors that have those conversations early. And we often go into comparing death as a life process to another life process of birth. And as an expectant mother, I was really grateful. I didn't want to think I needed a C-section when I was just finding out I was pregnant, but I was really glad that I found out about a C-section and what that would entail and what the risks might be really early in my pregnancy instead of in the 9th month when I needed a C-section. So I was really appreciative of that information early and didn't really think it was important in the first meeting, but I did, you know, as it kept coming up in subsequent meetings, then I realized, yeah, this is education. I need to learn about this. This is a possibility. So I would challenge providers to bring it up sooner than they might think they're comfortable.
But you touched on a really important thing there. When, you know, hospice is set up in a way that makes Dr. Beatty's life impossible, in the sense that when you put a person into hospice, you're saying we're not going to do anything more. And that makes the communication thing really hard. Because there are a lot of patients who are not doing well with their chemotherapy, but who aren't maybe they're going to die, maybe they're not going to die. They need your services.
Mm-hmm.
But if they give them your services, then they can't give them any more chemotherapy. And that's, you know, that's where the whole palliative care thing comes in. But
systems.
yeah, I mean, it really needs, I think that's one of the huge social things that needs to be addressed.
And patients need to know that hospice isn't a permanent choice.
Yeah.
So certainly, if things don't look good with your disease process and the cost benefit, whatever, how you do cost benefit for your health care in terms of quality of life and the costs, then certainly maybe signing up for hospice at some point might feel really good and be appealing. But then we have amazingly great medical technology, so something new might be available next month, and our patients can sign out of hospice and pursue that treatment. But what a great thing for them to know that there is that choice to kind of, you know, and I think that's the thing. So many people think hospice means you have a couple of weeks left. And I have had patients with cancer who were on hospice with us for over a year. And that's just it. They're just great choices. And
But the majority of people who get put in hospice have only a few days left, which is really.
I think the national average has come down to 2 weeks. Yeah,
Is
so
that what
it's just the national average.
It's really
for
short, I
hospice.
know it, yeah.
And it's interesting because we send out
2 weeks now?
2 weeks, yeah.
That's way up from what it was a
Oh.
decade ago. It's like 5.
Maybe.
It's been really short, I don't know.
And it changes over time for sure, but the interesting thing is that we send out family surveys after the first month to see what their experience was like. And one of the last questions is, did you feel like you had hospice, you know, too soon, too late, at the right time? And I would say like 99% of people say at the right time. And then the next line is, how long did your loved one have hospice? And it ranges from 1 day to a year and a half. And everyone in between there feels like it was the right amount of time. So it's such an interesting perception, right? When you're looking at it from the other piece where you're like, oh my gosh, thank God someone helped me. Like, that was wonderful. And you don't know what you don't know. Like, it was a great experience, whether it was a day or it was a year and a half. So that's what gives me hope to think like, okay, maybe we're feeling and it's only 2 weeks, but the experience is still, you know, a good thing. And then we can support the family after. But to get people to ask those questions and think about it before, we get oncology patients that have 2 weeks between treatments, and in that 2 weeks you say like, try it, right? Because you're not doing this curative thing, and you can come on to hospice and then go back and do that again. But you've had the experience of what hospice looks like. And that's a really,
you can have an initial meeting with hospice without, and finding out what's available.
Right,
and
or get
still
to know
continuing
our
treatment.
spiritual team and understand what it's like to have a nurse come into your home, because that's a different thing. Like, we don't have that happening all the time. And you get comfortable with it so that when it does happen, it isn't foreign, when it's a permanent position. And, you know, a lot of people try that. And I think it's a really neat way of talking to people about it too. Like, well, you have 2 weeks, like, you know, give it a shot. See what you think.
You can help them talk to their family.
Sure.
Because a lot of people don't know how to broach that. So you may not go on hospice, but you've helped them bridge the communication with their family.
Right.
Very helpful.
And it's not only, I don't think it's just the general public, but a lot of providers don't know either. They think that hospice is the end and then Medicare is going to say, you can't go back. but that's not the deal, right? You can go back and forth, and Medicare's flexible in that way. But you can't get both at the same time, which is difficult.
Yeah, there's actually an initiative for Medicare
Yeah.
to allow that.
Thank God, yeah.
Yeah, I
Really
think
needs
that,
to. It's just,
yeah, there are a lot of benefits, and they had that lung cancer study where they did both, you know, where they had palliative care along with treatment that was palliative chemotherapy, and the quality of life was so much greater for people who got both, and they lived longer than if they didn't have both. So I just think, well, yeah, when there are arguments like that out there, we'll be making different decisions.
And won't they cover both for children?
Children, yes, for children you can have both. So for anyone who's a pediatric and then goes up to age 21, I think, you can have palliative chemotherapy and any sort of life prolonging treatment and hospice at the same time.
It's typically not Medicare though, right? That's through your insurance
Or
or
Medicaid. Yeah.
Medicaid generally follows what Medicare does, but it would be different state to state, whether they adopted that or not. But like private insurances all do, Blue Cross does, you know, so I think that it is a pretty accepted thing, it's just not well known. That's a possibility, yeah.
I have a question. My advance directives are filed with the state of Montana, the advance directives and the bank of choices. And also with my personal physician. But last May I was in the hospital for some tiny little strokes. I was in the hospital for 5 or 6 days. My husband, who has dementia, just didn't produce those documents. I have it on my driver's license. I have that little thing. I cut it out and taped it to my driver's license. Or maybe it was to my insurance card.
It's on their license.
But what I'm wondering is how do we, especially if we're ill or we're unconscious when we go to the emergency room or whatever, how can we make that bridge with the physicians who are going to treat us there in the emergency room?
Don't you go on to the state? You
Is
don't.
that not, that's
No, you should.
So what I should do
You
is
should.
make copies for my children, have my children bring that
No,
to
I
you?
mean, I think what you should do is write a letter to the hospital you go to and say, this is a problem.
They should.
I think they
go
need to hear it. Because I run into this all the time. I can tell you,
Why
there
we
were
have it
2
online.
patients on my service this week who ended up on mechanical ventilators who wouldn't have wanted to.
Who wouldn't, okay, so I would simply make a letter to both St. Pat's and community, I
Yeah.
mean, because probably those will where
They
I'll end up.
need to hear, because we're doing a cruddy job of identifying people with advanced directives when they come into the ER. It's the
No one
system's not
asked
good.
And you could write a letter to the editor as well about
Sure.
your experience.
Absolutely.
But
If you have been
you can
at-
ask the hospitals to put,
Yeah.
to put be sure your advance directive is in your chart.
Yeah.
Okay.
And that's the thing you need to
And
do.
that's what gets it done, because they're not gonna go to
Why
the
are
state.
they
And I have a
hospital.
primary
Somebody
physician,
tells
at community, I have a primary physician at St. Pat's.
Primary physician won't make any difference.
Won't make any
They won't
difference.
even know you're in the hospital for 2
So
or 3 days.
yeah, right, they didn't. I had to call them. And
Yeah.
so what I should do then really is make copies of them, take them to the hospital.
Right.
make
Alert
sure-
everyone else
Put
to
these in
do
my
that.
chart, yeah.
But alert everyone else they
Yeah,
need to do that too.
when they hauled me in virtually dead, they couldn't find my file and choices, even though it
Why?
should have been
It's
there, you know.
registered, yeah.
I mean, I think it really, when you live in a town and this is where you're gonna be, you need to be a little more proactive about it.
But, and that is one of the benefits to having an electronic medical record, is that once it's in there,
Yes.
it will be in there.
Okay,
Paper
I will
charts
do
are
that.
harder, and I think that makes it more complicated, and not many people advocate for that. So,
So we
not many
gotta
people
get
show up
that.
at the hospital with their DNR and
Yeah,
say,
yeah, yeah.
can you scan this into my record in case I show up here in the
Yeah.
next, like, for the rest
But
of
you
my
can't
life?
do that.
You can.
And please write the letter, because the hospitals need to hear it. We're not doing a good job of this.
And I've been very specific in my
Good.
Yeah.
advance directives, okay.
But the people just don't understand that it isn't glued on your forehead.
Yeah, and it makes me nervous.
Yeah, oh,
Yeah,
I,
it's
real
rightfully
nervous,
so.
yeah, yeah.
There's been
That's the
attempts to
biggest
put it on the
thing.
internet. And there's a group in town that did that for years, and they just,
It is.
no
on
one
the
really paid
internet.
attention to it.
Yeah.
You know, the old paper charts, you put in the chart, and God knows what the charts are.
Yeah.
I mean, the electronic thing should work until the electronic medical record system goes down, which it did in St. Pat's with 3 weeks ago. Screens look like.
Every other weekend at 2 a.m. on a Saturday. No. But they, they do go down from time to time, and then you have to assume that even if it's in it, the people involved in your care have to look.
Yeah.
Yeah.
And
Yeah, it's not gonna pop up with a little red flag when you come in.
we don't
And I had
always do.
excellent care, but I mean, there could have been a possibility
Yeah.
that I would have
Yeah.
needed those to be followed.
Absolutely. No, the system needs improvement, no doubt about it.
And if your children do not live here, you need to have someone who lives here who is your actual designated
Okay.
power of health attorney.
Your own personal death squad.
Yeah.
Knows what you
The death panels weren't a bad thing, honestly.
I want.
It's scary. I mean,
Having my girlfriends and husband and kids and,
Well, I think the
it's
most,
my team.
the most important thing is the communication, to tell people
Yeah.
what you want, what you don't want in your family.
tell everybody you know. I mean,
Yeah, that's what I have.
somebody will come by the hospital to see you and say, why are you putting her on the bed?
After 25 years as a critical care nurse, I would say the single most certain determinant that your wishes will be carried out is if your family has had that conversation with you and they've agreed that they're going to do what you want.
And I have.
They're going to go to the hospital and say, and insist, or your designated medical decision maker is going to go to the hospital and say, she has will, she has an advanced record for medical care, blah, blah, blah. Here it is, and you're going to follow it.
To my kids.
And if your family is divided because you haven't had those conversations,
That's a problem.
the truth in most cases is that your wishes will not be followed. Instead, the hospital and the people who work in it will be very, very careful
Not to.
not to until the family reaches some kind of equanimity. Not equanimity, but equilibrium. The worst prognosticator for quality of end of life, I think, after all those years of critical care, is the patient who's familiar with their disease and having thought about it for years says to their children, I want to talk about how I want things to go. And they say, oh, Daddy, we don't need to talk about that, you're going to look for it, or whatever. That's the single, to my mind, in my experience, that's the single worst bellwether for things not going well. You have to have this conversation.
Just a quick response to our Scottish friends' experience of the intensive care unit. I've had the unfortunate but blessed experience of being there with a few friends over my lifetime here in Missoula. And it is like a well-lit gallery. And that bay of windows behind the rooms where the intensive care patients are is pretty dramatic, but I think what she's experiencing is because everyone seemed calm and she said cheerful, but I'm sure they were just calm, direct. They're working back there. And so I'm not sure that in very many places in hospitals in the world, I don't know this, but I'm not sure they just let people into the intensive care unit. Sometimes perhaps they have one person who's allowed in or family members, but I'm sure it gets crowded back there. So what I would say about your experience was it reflects the excellent working conditions and the morale of the people who are caring at critical times for our loved ones. And if you were in a hospital, maybe in, I don't know where, somewhere in the inner city, it might not be like that at all. So that would be pretty frightening, but your experience is obviously good because those people are a high-tech team, and they're working, and they're not emotional. And so you don't pick up on the fact that, yes, this person is on the edge. That might have been it. I think we have excellent
We've touched on a lot of different things here. We haven't looked at what doctors will do when they know the end is coming, but they're not in these critical situations. Doctors have one of the highest rates of suicide of any profession. And a great number of things like plane accidents with physicians at the wheel are actually deliberate wrecks. Docs don't want to go there.
Yeah, that seems reasonable. I mean, I feel like that's a difficult thing too. I mean, my son is 7 and he just turned 8 and he just got a pet, a lizard, and his first question when he asked for that was, well, is it gonna die? I was like, well, yeah. I mean, it is eventually, and it could be tomorrow if we get a bad one, and it could be 12 years, like, we don't know this. But the idea of sometimes we talk about things with animals and pets, and we sort of take that away from the human experience, and I think a lot of people feel like we're more humane with pets than we are with ourselves or with other people, because it's a hard thing to look at. It's a hard thing to look at. And someone who might feel that suicide is okay as a provider might not be okay with physician aid and dying, because who am I to say that I could take your life no matter how miserable you were? I mean, the moral compass on that is so confusing. I just can't imagine making those decisions. And if you hadn't seen how that would go, how would you know that wasn't something you wanted to go through? I mean, it's complicated.
One of my favorite patients was an elderly gentleman with lung cancer 6 or 7 years ago, who I'd known. He'd been in jail or in prison forever. And he said to me one day, Doc, what are you going to do when I get worse? And I said, well, I'm going to put you in the infirmary, and I'm going to put an IV in, and I'm going to do what I can to make you comfortable. And he said, are you going to kill me? And I said, no. Prisoners are really afraid of that. And I said, no, I'm not going to kill you, but I'm going to do everything I can to make you comfortable. And that might shorten your life a little bit. Oh, Doc, thank you. That's what I wanted to hear. And I've never forgotten that. That people, they understand. They don't want to suffer at the end, and they want to slip out.
Yeah, I think just following on from that, I'm kind of curious about each of your experiences when you first came into the medical profession, and your thoughts about how you wanted to die, and now how that's kind of changed.
I think the only difference with doctors, A, they know what death is, they know what disease is, and I think you're right on. They know how to do themselves in quietly. I mean, there was also data once that doctors with Alzheimer's disease live shorter than other people. And I think that's because they figured out, I don't want to be around. How do I not be around without causing too much disturbance? And it's not simple. It's not easy to do that. I mean, just an example that comes to mind is, in Oklahoma recently they tried to execute a prisoner, and so they didn't know what they're doing, botched it. I mean, I guess you've probably all heard that story. It just gives me the creeps. I mean, there's someone who didn't, obviously a non-physician, non-intelligent person, thought they knew how to do it. But there's ways of doing it that it's comfortable, no one knows. They have Alzheimer's disease and they don't wake up in the morning.
Right. Yeah, I think that, I know a friend whose father was a physician, and that he had dementia at the end of his life, and he was in a skilled facility, and she came to visit him, and he said, and they went to have lunch together, and he said, I'm not eating, so he decided not to eat to shorten his life. And he said, and I can find the 4 other people here who aren't doing that, who are doing the same thing. And they had this sort of understanding about that. They pushed their food around, they didn't really eat anything, and they knew that starving to death wasn't something that would be painful for them, and they understood that they had the control of that. And for her, that was horrifying. Also, she felt like that was his choice.
Yeah.
And I think that that's something that we don't offer that to patients. I don't think providers are like, and here's the thing, you could just for the next 2 weeks.
Well, and there's really good documentation on that. That you don't feed, if people stop eating and stop drinking, very quickly, you lose the drive, and then you're gone. I mean, it isn't painful, it isn't distressing, and sometimes, I mean, I'm sure there are exceptions, but by and large, it's a pretty good way to go. Right? And people, that's one of the arguments against doing the feeding tubes and the IV fluids, and that's just prolonging something that, I've always said there are a lot of things worse than dying, and I just really believe that.
It's so hard to talk people into not getting feeding tubes and IVs.
Yes. Well, that's where the families really come in. It's cruel to not give them food. Well, it really isn't.
You're gonna be thirsty, you're gonna be hungry. Well, that's why you have medicines.
Yeah. And you can use the little sucky things and make people comfortable and.
It's harder, I think, for the caregivers than it is for the patient in that specific sense, because we've all built our kitchens around love. You know, food is love. We eat our kids like that is a way that, I mean, I'm happiest when my kids are eating well, and that's something that we all sort of have ingrained in us. So that's a difficult thing to turn away from. I get that. What about you, Dr. Caramore? How did you change your mind from when you were first starting medicine till now? Same.
I had no sense coming into medicine. It just that was not on my radar screen at all. But from time, I said it earlier. I really do not want to die in a hospital. Just as soon as I'm going to live a long, healthy life. I mean, if something catastrophic happens, I think it might be out of my control. But I would not want to die in a hospital. I want to die on a comfortable couch or bed in my home, surrounded by people I care about.
A lot of fentanyl.
Yeah, with a lot of fentanyl. With my dog.
Wait, what was that again?
But, you know, I just, and again, I think that people go through treatment in hospitals for a variety of good reasons, but in my mind, you know, if I knew that I was dying, the downside to being in the hospital outweighed the benefits.
And our society is so fragmented now that for many people, dying at home really isn't an option, or, I mean, the mechanics have gotten so complicated. I have 4 adult children in 4 different places, none of them here. A couple of them would have to quit their jobs, basically, if I chose to die at home. You know, I don't see any way they could be here for 2 months. It's just, I don't know, you know, I've always said that when I got to that point, I was going to climb Cloud's Rest in Yosemite, which is my favorite mountain, and just jump off. And one of my sons pointed out to me that when I got to that point, I wasn't going to be able to get to the top of the mountain. But I really do, you know, I have a feeling if I had a condition where I knew where the end was, I might well do something to end it gracefully.
The helicopters.
Yeah, right.
Your son is like, or I leave you there.
Yeah. A couple of them could haul me up.
The Eskimos had it right.
Yeah.
Grandma just went out on the ice floe.
Right.
Right. I mean, can you imagine
With
the shock
ceremony
if that happened
and
today?
with love. And
Oh, yes.
I mean, it was a part, yeah. Oh, it'd be so
That was an
nice.
act of love for Grandma.
Yeah,
And she expected it.
right.
You're right. I mean, that would make headlines all over the world. if we did that.
And the absence of a hospice house here
Well, I feel
is
others.
pretty
Yeah.
acute at this moment.
Yeah.
The hospice house is just the ice floe, right?
Yeah.
Right.
Ice flow
But I had
with
one patient once that said, I want to die in the hospital. And I asked her why. I said, if I die at home, I'll die in that bedroom, and my husband would walk by that room for years and years, knowing that's where my loved one died.
Well, yeah, because the alternative for you would be a nursing home then.
Yeah.
Right. Right. I mean, I think that these are good things to bring up because we do get to be the consumers of our healthcare, you know, and say like palliative care is what I want, or, you know, how can we make these changes? But to look at that, we have the choice to make that different. Does anyone else have something that they'd like to talk about?
Well, one of the things that I find myself, I mean, I'm of course, the bull and the pen and all in the brain and that conversation, but when I talk about having a death squad, I mean, I really mean that, having a group of friends and family members who really know that, you know, if I get to this point, I don't want to be here anymore, but I've also had 2 really close girlfriends, and I'm going to see a third who have died of cancer, and when it came down to it, they just fought dying so intensely, and that I didn't know how. I didn't, and I don't, and I'm going to spend time with an old friend who, she's not dying, but she will die. I mean, she's going to die. And they didn't want to talk about it. They only wanted to talk about how they were going to get through the next round of chemo and what else they were going to do, and it would be inappropriate. I don't know. Do I say, oh, come on? You know, I mean, how do you deal with people who are clinging so tenaciously to every last treatment, every last there will be an experimental treatment, there will be an alternative cure, and how do you, I don't know that it's my place to.
Right. You can offer, my own mom, I was a hospice nurse for years. I said, Mom, how do you think you're doing? Why? I mean, my mom never wanted to talk about anything. I was just offering, just offering.
I think there are going to be situations where that's the way someone is, and that's okay. I mean, not everyone's going to die in the sort of way that we idealize, but I want to just kind of talk about a case I had today that I think highlights some of these points. There's a guy came in about 2 weeks ago to the hospital with a bad breathing problem and pneumonia. He had some underlying lung disease that had never been diagnosed, and he quickly deteriorated and ended up on a breathing machine. His 2 sons swooped in from Seattle and are very clear with staff. He didn't want to be on the breathing machine. The one son says this. He never wanted to be on this. They had the conversation. The other brother insisted on keeping him on because he just wasn't ready to let go. So he's on the breathing machine for 5 days, spends a couple days in the ICU, and moves out to the hospital floor where I kind of take over on his care. And the guy has a few lucid moments, but he's very delirious. He's confused most of the time. In the last couple of days, he's just been sort of calling out his pets' names and things like that. And it's become clear he's got incidentally has been found to have a large tumor in his lung. It's probably a lung cancer. As the picture came together, it became apparent that this man is likely in the last stage of his life. And I've been talking to the one brother who really wanted to transition his care over to a hospice type arrangement as soon as we could. I've been talking to him primarily up until today, and he'd been telling me, my brother just hasn't been ready. I talked to him on the phone, or I talked to him in person, and he keeps saying, let's give it another day, let's give it another day. So finally, this morning I asked this brother, I said, get your brother in here today, let's have a conversation. And it was really interesting. The one brother I've been in contact with first had shown me notes from the conversation he had with his father. It was very clear we were doing things he wouldn't have wanted. But what won his other brother over was a conversation about his dad's independence. And his dad had made, among his other preferences for healthcare, he had made it very clear that if he lost the ability to live on his own, hunt, fish, hang out with his cats and his dogs, he didn't want any part of it. This was not a life for him. And I brought that up today, and the brother who'd been holding out almost instantaneously told me, all right, we're done. And so I think this story highlighted for me the idea that you don't necessarily have to lay it out to your family members that you don't want a feeding tube, you don't want an IV line, that, other medical intervention. If your family has a sense for your values when it comes to stages of life, that can be as important, if not more powerful, than any knowledge of tubes and all these things.
That's a good point.
I just think, for that death squad idea with girlfriends, I feel I can see that happening with my friends as we develop in our conversations about end of life, because I think that's really fun to talk about. But I think that we set our goals and we say these are the things that we want, and then, that will probably change for a majority of us. And I want for someone to say to me, how has that changed from when we talked about it before? And it might be a hard thing to say, but and I might have a good reason, but I want someone to bring it up so I remember what I had thought before, and then we can process that, and we might come to the exact same place that I am right now. But that would be my challenge to my friends, is to say, well, could you bring this up if I change my mind later? Just remind me of what I was thinking, so that I can explain it, or I can be brought back to that place. That's a tough thing. We had a conversation, I just want to briefly touch on this because I think it was so exceptional, at the Death Cafe yesterday. And my mom, who has been a hospice nurse for a long time, talked about and lost a partner to a brain cancer. And he was on hospice for 2 days for a hospice nurse, and he's a physician. And so they were holding out hope and doing everything they could until the very last minute. So and that's not what she would have ever said before, nor would he have said that as an ER doc. But she said, to look and talk about death is like looking into the sun Like, it's so painful that you can't do it for a long time, especially if you really love somebody. So they hadn't even talked about it much either. Like, they would touch on it, like, what do you want? And then they would cry, and then they'd be like, we're just gonna live for today. Like, we're gonna move forward. Because it was so hard to just look into the sun just for that short amount of time. And I just think that's a really interesting way of looking at it. So, it is a hard thing. If we could all just go sunblind, that'd be awesome. So, thank you guys for coming. If you have any additional questions, certainly you can sign up to have reminders sent to us, and you can call or email anytime. We will be doing this again next month, and I'm so sorry I've forgotten what the topic is. But the month after that, in July, we're going to be talking about end-of-life experiences and afterlife, and sort of examining what our different thoughts are on that. So that'll be kind of fun. Yeah, thank you guys so much for coming. It was a really vulnerable.